Thank you for that kind introduction. Thank you to the organizers, and also thanks to the earlier speakers. It's great to learn a lot about different areas and things that I have to look up to understand what they actually are in the basic science world. But also, it's directly correlated, my talk is directly correlated to many of the things you've heard today, which is how do you translate this into a human intervention that will change patients' outcomes. So here are my conflicts of interest. They're super exciting. They're also available online if you'd like. But this is the key message, that if you take away one thing, is that pathophysiology and epidemiology are no substitute for a randomized clinical trial. It doesn't matter how many single cells you isolate and how many mice you subject to your new and innovative therapy. Unfortunately, you have to do clinical trials, because otherwise we don't know what they do, what happens in the human environment, which is really what we're after in this experience of trying to change human health. So here's a nice quote from Rob Califf, the FDA commissioner, talking about why randomization is essential. And these are simple things on everything from your new molecule, but also workplace wellness. I mean, who doesn't work for somewhere that has a workplace wellness program? And it turns out people did a randomized trial and they don't really change outcomes, because no matter which way you looked at it, we may not kind of want to dwell on that too much, but you got to randomize everything. I was nice enough to have a coffee that Heather bought me earlier. She randomized me to one type of coffee versus another, and I think I'm still okay, so I think I'll probably have a few more. The reason we also test the new things is so we can get rid of old things. So there are about 10 million leeches per year that are used for medical care. This is from an older study. We don't use leeches in Alberta. That's slightly west of here. We don't use them, but they are used. Rotating tourniquets are no longer used. And that's because people did studies to show that it was not beneficial. Neither is digoxin, nor is bloodletting, both of which are not recommended anymore by any guideline. But do we really need more heart failure therapeutics? And so you could argue in many different contexts why we do or don't. And you can see this list of different questions or way people answer that question. And quite often, people say, yes, it's a death and disability, it's very high, which we've heard a lot about that. But also we can use the drugs we already have just better. That's a heart function clinic approach. But as you go down the list, you've heard a lot about number 6, which is, I wish someone would cure this. And that's often what patients want. And that's like the eternal optimist in me, thinking that one day that will happen. But also many of the things we've talked about or you've heard about today, you would have heard many potential cures coming down the pipeline. Whether or not they're 1 to 10 years away, that's good to be an optimist. Alberta being only 4.8 million people compared to the 14.5 million people you have in Ontario, it's good to put this in context. First of all, Alberta is west of here. It's west of Mississauga, in case you're wondering where that means. But there's about 8,000 people newly diagnosed in Alberta every year with heart failure. So that's the context. Those are the people you're dealing with. They spend about 7.5 median length of stay in hospital. It's not bad, it's about average for Canada, but you can see about a quarter are readmitted within 30 days, and that's not because healthcare is terrible in Alberta. It's actually about the same in Ontario, and it's equally bad if it's Michael doing this or somebody else doing the care. It's not always down to the quality of care. And so that means there's a lot of hospital time, dwell time for those patients, and that is because it's a difficult disease to treat. You have to do a lot of things. We always talk about acute MI, STEMI, acute coronary syndromes, whichever your best frame of reference is. That's on the left-hand side. That's the risk the patient faces. It's a low-risk environment. But we've optimized all our care to treat a heart attack. On the right-hand side is the risk for a patient with heart failure. There are much greater risks for people for having death or disability compared to any patient undergoing an MI. So we have to get around the risk part, which is one part of the equation, and also the residual risk, which is the amount of risk over and above just living a normal day-to-day life on Yonge Street and Yonge and Bloor and wondering about your risk of being hit by a bike. So this is the other part, is we have to then go to the next step, which say, what are actually the care gaps we need to fill? So care gaps always depend on your perspective. If you are looking on the left-hand side of this picture, you'll see that that's one view, and it doesn't look like it's tremendously difficult. There's probably some water down below, but if you step over like 5 feet and you straighten out at that angle, you can see there's a torrential flow of that river. So care gaps are always about your perspective, and you may have your own perspective on this as well for other disease states. So you need to fill a care gap with any of the basic science work, because part of that is fundamental discovery, but part of that is working towards things you need to test. So we do lots of gap narrowing exercises called randomized trials, and these are some examples of some of those. So implementation or strategy trials, like guided trial testing NT-proBNP, didn't change outcomes, good we tested it. multiple complementary interventions, and COVID was a terrific example of using different ways to say, well, does dexamethasone work? Does other drugs work? And those are platform trials. In public health interventions, you've seen the Dan flu results. If you try to get after flu vaccinations for an entire country of Denmark, that's the Dan flu trials, and they're trying to do that as a public policy trial. And then gene variant trials, first in human trials, of which you heard a couple of really cool, exciting stuff earlier today about, this may be closer to testing in humans than we thought. But any clinical questions that come up, and you don't have to read all of these, but the next time that as a clinician we see patients, we can ask a question about this patient, and we'll find that there's a list of questions we might have. Why am I doing this thing? Why am I doing this process? Why am I doing this treatment? And quite often there are a lot of unanswered questions on every patient encounter, and this is just a list of things that we may or may not want to tackle. I, with a lot of help from Heather and colleagues in a global trial we tested whether or not dietary sodium mattered or not. And that was a really important intervention, not so much because of the result, but we actually tested whether or not that older statement of limiting sodium was important, but we tested it in a randomized trial because we needed to have a better answer to give to our patients and to a health system. So those are some of the examples you could see that any clinician might come up with on a daily or individual patient. Now, I was asked to talk about the future of heart failure trials in Canada. That's a broad topic. This is just a smattering of trials that are ongoing actively or about to recruit. So this is like a smattering. It's not a comprehensive list of every trial recruiting. And I'm using the terms HFrEF and HFpEF, and those with mixed ejection fractions means that there's a broader inclusion criteria. But as you can see on the left-hand side, we're talking about things such as an AFib strategy, which is the best way to treat it. Do we do medical management versus ablation versus different types of ablation? ICD, should we still use them in patients in this era? And as you go through, you can see that there's a kind of a trial for every patient, no matter what their phenotype. We often don't match that up, and we do a terrible job of matching up patients with the trial and the trial with a patient. But all of these are under experimentation with a randomized trial, and they're being tested because they got out of the basic science lab through the translational environment, past the phase 1 and phase 2 valleys of death. But they're now ongoing in Canada, enrolling patients, and we'll know whether or not they work or not. But the solutions, and I'm going to, it seems like a bit of hubris to say we got some solutions to this. I'm saying these are potential solutions that may have some framework to look at. But the solution one is when something comes out of the translational environment and somebody wants to go test it in an RCT, the yellow box matters probably the most, which is engage people that do clinical trials because that is a clinical science expertise, much like it's a science expertise, just like running an ELISA, just like any of the single cell assays are being done. There's a clinical and scientific expertise around how that's done, and it's not like anything else that simply just do a clinical trial. So often we have to make sure that that's done early and engaged early, but design does matter. You have to have either a narrow or a broad population. You have to think about the acuteness of the disease or as a chronic disease. Which is a piece you're actually thinking this thing might work in. We have to also stop doing trials that are poorly designed and underpowered. Not enough patients leaves you with no answer, not just the wrong answer. And so sometimes you have to really put the brakes on and say, let's do the right trial, right design, and right patient population, and use the outcomes and methods that matter to that patient group or population. Is it a clinical outcome, a biomarker outcome, or an imaging outcome, or a combination of those all together? That actually matters in the design phase, because if you just show it changes a biomarker like NT-proBNP, but it doesn't change structure and function, well, you may then wonder, is this going to change the signal of clinical outcomes down the road, or is that tightly coupled or loosely coupled? So this is just an example of, this is by no means comprehensive either. You can have parallel trials, crossover trials, platform trials, cluster randomized, step wedge. You pick the menu based on what the intervention is, and we're currently designing a step wedge cluster randomized trial. It sounds like fun to everybody I know, but that also involves a totally different strategy than doing a parallel drug versus placebo trial. And so you really have to think carefully about what is it you want to show in this trial of this stage of this thing you've developed, if it's a device, drug, intervention strategy, or EMR intervention. The other thing is context matters, and this was done by Safia Chatur, who's in Boston now. And what she did was put together the summary of what's called Prompt AHF, which is an EMR-based intervention that was done by the Yale group of researchers in heart failure. And they said, well, these trials show that these drugs worked in patients with HFrEF, so that's everything from ARNIs and MRAs and SGLT2s, they worked. But when prompt was done, it didn't show the same outcome that you would expect, that you have this EMR prompt and these drugs work wonderfully and everybody follows the rules, because people don't follow the rules. I jaywalk, probably everybody else jaywalks at some point. We don't all follow the rules all the time, so this is what happens when people don't follow the rules. But what happens is you can see very clearly that policy level, provider level, or patient level may provide you with different outcome and results. So you have to be very careful and think through all the steps of what you might be testing in any intervention, because if you don't implement the therapy, it's really as good as not starting in the first place. It's not like one of those, the journey is the destination. It's not one of those things. The destination is actually the destination. The other part to think about is solution number 2 is the targets. So targets include inflammation. I put air quotes around that too, because all of you are looking at me like inflammation means so many different things, and it does. The natriuretic peptide system, you can look at calcium handling. We heard a little bit about today with phospholamban, guanylate cyclase, PDEs, metabolism is another air quotes because that's a broad term. Then on the right-hand side are things that probably many of you don't think much about on a day-to-day basis, which is EMRs, communities, hospitals, the volume management that Mike has to handle with patients who are volume overloaded, how clinicians practice and how they generally are hard to navigate, and patient education. And the solution number 3 is think about the precision of what you want to estimate. So think about if heart failure was a cancer-based cancer, and how would we approach this differently? We've heard about heart tissue, so liquid and tissue biopsies, but all of those things about how cancer is approached is a much better setup for testing hypotheses of any new therapy. But what happens if your trial of doing things is neutral and you don't show it? Is it that you just got the design wrong? You got the biomarkers wrong, whatever it is, you just have to make sure up front you don't get to that scenario where the precision is lost because you just designed the wrong experiment. So solution number 4, and this is total hubris because I'm the worst at engaging people, but public engagement in trials is important. And if you don't do that, honestly, nobody wants to enroll in a clinical trial and volunteer their time if they're not engaged. And I think that's a volunteer spirit you have to engage people in. But if you don't have patient partners and true patient partners, then you're not going to get a lot of clinical trials done, testing those great therapies. Engaging government, sadly, does have to be done, good or bad, and other NGOs. And we have a lot in Canada to be grateful for in terms of rich and talented, highly qualified personnel. But if you don't put them to their best, onto their best platform, you're not going to get very far. So collaborating within groups, between centers, and God forbid outside of Ontario, I don't want to say that, or outside of Toronto even, but you really do need to think about how to collaborate broadly. And we love collaborating with people in, let's say, the Toronto General, because we like working with the people. We like doing the science together. We like having coffee together. And those things actually matter when you're trying to go to the next step of a clinical trial. Old school engagement is not the way to go. This is an old school trial. A patient drives from, let's say, Oakville to Toronto General, pays for their parking, walks through the maze of buildings to get to their clinical trial involvement. So when patients are engaged in clinical trials, we have to think about this old school technique, which is not very engaging, but it's not very engaging for anybody. The PI, the study coordinators, the research team, they're doing a lot of work that is kind of mostly meaningless. It's meaningful for somebody, I'm sure, but it's mostly meaningless. But part of this is it's not really valuable work. And a lot of that human capital, the time is lost. So we need to think about how do we solve these problems. But the PI who gives up their summer writing a CIHR grant, who I'm sure many of you have done that, is not very happy either. So we need to think about how do we integrate all these different e-apps and e-things into the world of clinical trials, and they're all possible. It all can be done. We just have to apply them and think through what we need to show. Validation, we saw something on plethysmography. I said it better than Doug Lee. That's all that matters here. He was given that long title. But you have to validate every measure really well before you apply it into human clinical practice, and especially clinical trials if it's part of the outcome. The Accelerating Clinical Trials Network, I'd encourage you all to look up their website to read more about this National Consortium of Clinical Trials and the work that's being done there that will help all of us and float all the boats. But what we're really getting to is the trials where we can do something like this, where we've got like this huge clinical trial environment for Canada, We don't want to lose people, but you've got the study team, which will be sitting in the comforts of the Ted Rogers Centre, like lounging with their coffee and say, drone, go find that patient that we enrolled in a trial. We can't seem to locate them. The drone is on it. And of course, they find them and they visually acquire them because, of course, we're recorded every day, all the time. And they said, oh, the drone, the patients requested more pizza. The study team can say, oh, pizza's totally authorized, so pizza's delivered. That's the type of environment we need to get to, where patients are really engaged and found and can participate and really not be lost to the overall follow-up of clinical trials and research environment. So if that hasn't been too dismaying, honestly, clinical trials are valuable and we love doing them. The future is really now on how we do clinical trials. So we have a lot of expertise to how we engage people and our partners. And it's very bright based on the things I've heard already today is the molecular targets and other EMR entities. You'll hear from Emily Cito on things around Medley. Those are things that are really super exciting for all of us. So thank you for your attention. I apologize for the blitz of slides. Thank you.